Good evening, everyone. I welcome you all to the second psychodynamic case presentation. This is an initiative by the Indian Psychiatric Society Faculty Development Subcommittee in association with IPS Psychotherapy Specialty Section, the IPS PG Education Subcommittee, IPS UG Education Subcommittee, and the Indian Teachers of Psychiatry. So, as you're well aware, the last time we had a case presentation by Dr. Rajamani, and today we have Dr. Harshita H.A. She's an ITOP Must Enrich Grant Awardee and an ITOP Travel Grant Awardee. And the session would be chaired by Dr. Pratap Sharan. Sir is a professor of psychiatry and the head of department at All India Institute of Medical Sciences, New Delhi. Myself, I'm the moderator for the session today. I'm Dr. Varun Mehta. I'm also an ITOP STEP scholar and I'm professor of psychiatry at CIP Ranchi. Uh, Without any delay, can I request Pratap sir if he has to share a few words before I can request Ashita to share her presentation? Sir, please.
Good evening, everyone, and I'd like to welcome all of you to today's session. I had heard Arshita for the first time at Raipur, and the cases are, I think this is the same case that was
Yes,
discussed there, but we have more time to discuss it properly this time. So I'm really looking forward to hearing you. From what I remember, the case was quite interesting, and it is worked out quite well, in the sense that there is a formulation, there are steps of psychotherapy. So there's much to learn from the case. So I would request Varun to take over the proceedings. Welcome, everyone.
Thank you, sir. So, Harshita, request you to please start with your presentation. So there'll be interruptions in between. So, sir may ask you to interrupt in between where he would want the participants to give their comments, contributions. So just be prepared for that, and also hoping you'll be a bit slow in your presentation so that it is for everyone around to grasp. Please, Harshita.
thank you, Dr. Varun, and thank you, Dr. Pratap, sir, for giving me this opportunity. And ITOP and IPS Faculty Development Committee, subcommittee in specific. So this case, which I'm going to present now, is my MD Psychiatry Psychotherapy long case, which I did, and I did this therapy sessions in NIMHANS under the supervision. So my supervisors were Dr. Geeta and Dr. Rashmi, and therapy group meetings were held once a week as a supervisory arrangement. So it was a case which lasted for more than 6 months, from February 29, for 4 months, February 2019 to July 2019. So I would want to declare that the consent for the psychotherapy submission is obtained from the patient, explaining the non-disclosure of his identity. Also, the consent is all obtained from the treating psychiatrist and psychotherapy supervisor. So the case summary of the case is as follows. Mr. SRK, who was 23-year-old single male, who was a BTech discontinued, from upper middle class family of urban part of neighboring state, presented with illness for 13 years from 13 years of age, insidious onset, continuous course with intermittent exacerbation characterized by feeling of pervasive low mood, decreased interest in activities with intermittent suicidal ideation and attempts of high intentionality and lethality, with impaired biological, social, and occupational function, along with academic decline since 10th standard and drastic decline during his graduation course. So, temperamentally, he was quiet, emotionally reserved, shy, timid, and initial withdrawal to the new stimuli. Personal history is that in childhood, mother, due to her job, had to stay away from him when he was 1 year old and used to visit him once a week. And he grew up with his maternal grandparents. Maternal aunt took care of his materialistic needs. Father stayed with him until 7 years of age in his maternal grandparents' home, and later he shifted along with his mother and younger sister to his mother's workplace. From his 13 years of age, all four members of the family started living together close to his grandparents' home in his native city after his mother's transfer. So there was history of alleged childhood sexual abuse from 13 to 16 year of age. Family history is that there was inconsistent parenting with a disengaged mother and punitive father. He lives with his parents and younger sister at the point of contact with the psychiatry setup. So there was no mental illness in the family reported. So, okay, if I have to present in a chronological order, so he was functionally normal as per him till 13 year of age. There was onset of sleep disturbance from 13 to 16 year of age and difficulties in studies, perceptual distortion, searching for painless mode of death. Also, there was history of childhood sexual abuse from 13 to 16 year of age. Perpetrator left at age of 16 when the client was 16 year of age, and then the self harm behavior started. So the first attempt was he tried to consume strip of diazepam tablet. Then, in the graduation course, against was against the patient's choice, and the patient was not interested in course, which was around 18 year of age. So he was not regular to college. Mostly stayed back in the hostel. There was poor sleep along with the searching for suicidal methods continued. He consumed potassium permanganate in the first year of graduation, and he also was detained from the college due to the poor attendance. Then he stayed at home for a year. There was no interaction with the friends and family. He mostly watched movies and slept late night. The poor sleep occasionally did not. There was poor sleep. He occasionally did not sleep for 2 to 3 days at stretch, and also he started abusing on the counter medication for sleep. He started working in the known place under father's insistence and around 22 years of age, which was against his own wish again, and worked for a year and later left since his hard work was not recognized. So later he came to Bangalore and stayed with the childhood friend and started working as a web designer few months, and later he left the job due to the lack of upgradation. Sleep issues, however, continued. He stayed back at home in Bangalore. There was sense of burden and suicidal thought worsened, and it is depressive symptoms worsened at this point of time, and he was brought by the friend to the hospital, and then he was admitted in inpatient setup. So the clinical diagnosis by the treating team being dysthymia with severe depression without psychotic symptoms and social anxiety. So there was therapy referral made, and the reason for therapy referral was that interviews with the patient revealed significant distress around holding on to this term of perfect son associated with the ideas of guilt, worthlessness, sense of burden towards the family, long-standing self-harm thoughts, even during good functionality. There was poor coping skills with various personality factors identified by treating team and referred to therapy with a focus on understanding the schema around perfect son and improving his coping skills. So theoretical basis for yes,
Dr. Harshita will just wait here if
yeah.
anyone has any quick questions. Does anyone have any questions for the sum till both the case per se? Okay, I think let's continue.
Okay. So therapy was initially started with the focus on CBT principles. So later it was shifted to psychodynamic principles due to the exploration of childhood history showed unavailable mother and punitive father. Then repression, and there was internalization of the negative emotions, that especially anger and aggression, which was viewed as bad self, to maintain the good relationship with the desired object. Then early childhood experience of bullying and feedback received by the environment that he is vulnerable and made to keep to himself. So, repression of the negative emotions of anger, aggression, and assertion, which he viewed as bad self, repeated in future interpersonal relationship, which led to poor ego strength. It ended with self destructive behavior whenever he sensed the loss of his desired object. This nature of interpersonal problem and sense of recapitulations of pattern of relationship experienced in early childhood and adolescence led to formulation of Kleinian's object relations theory for making the interpretation. So, if we come to psychotherapy formulation proper, the chief emotions that was seen in most of the therapy sessions were anger, resentment directed towards the self, and also anxiety when the core conflicts were explored. The defense mechanisms used were regression, fantasies, and splitting. So, patient perceived his omnipotent mother in infancy as a good object. When mother left him to another city due to work, her unavailability frustrated him and consequently had aggressive impulses towards mother. However, this impulse was perceived threatening to his relationship with mother, and he eventually got attached to the cars brought by mother every time she visited, which represented a transitional object in the absence of mother. So patient also perceived his father as protective and omnipotent. That is a good object. But father's perfectionism and punitive behavior, which he viewed as bad object to discipline him in the absence of mother, frustrated him and evoked aggressive impulses, which he considered as bad self. But he feared retaliation from father at the same time. So he internalized this bad object, that is father's criticism, and tried to pacify the bad object by being submissive and obedient son. So he also projected his bad self aggression to father and introjected father's criticism and perfectionistic attitude. He self identified with this quality, and any deviation from this caused him immense anxiety of losing the desired object, that is, father. Hence, continued to be submissive and obedient to his father, suppressing his assertion. So, is clinging on to this transitional object, father's restriction on the patient to socialize with peer groups led patient to withdraw from father's presence, and he tried to regress to this transitional object brought by his mother, which are toy cars, which represented him, the omnipotent mother to him. So when there is is link for his a link of his conflict to his relationship with the perpetrator as in the perpetrator of his childhood sexual abuse, which happened between 13 to 16 year of age, during the time of adolescence. So the patient attachment to his transitional object, that is toy cars, actually got him close to this perpetrator, who was an older female with collection of toy cars, who cared for him initially, and patient identified this omnipotent mother in her and viewed her as a good object. Sooner, perpetrator's abusive behavior frustrated the patient. He repressed his aggression with a fear of losing the desired object, made him submissive, and tried to appease obedience. However, the perpetrator disconnected from him at the verge of his assertion. This actually strengthened the patient's psyche, who further became meek and submissive, associated with being punitive to self, and self harm behavior started. This submissive behavior, in order to please the closed ones, made him to choose an unwanted professional course and unwanted jobs and failed to thrive. So if I give a better schematic representation of this formulation, so there was failure to establish secure attachment to desired object in early childhood. Later, there was splitting of bad object, the punitive father and unavailable mother, from the good object whose protective father and caring mother. So, repression of his aggressive impulse due to the fear of destroying or losing his desired object. And also, there was a projection of his bad self, that is being aggressive to father, and introjection of father's criticism and identifying himself with this quality, which led to self punitive behavior. Any deviation from this, that is, failure in academic and profession, regarded as vengeance against authority figure and led to anxiety of losing the desired object.
Okay, I think we'll kind of
Yes,
stop
sir.
here for the time. And if anyone has any questions, the way to learn usually is to speak. Otherwise, psychodynamics is a little. So I'll request everyone who's here to put on their videos. Request everyone to put on the videos. Dr. Kumud, Dr. Anup, Dr. Aishwarya, Dr. Shubham, Dr. Sajal, Dr. Akshay, Dr. Tony. Yeah. So, Kumud, would you like to start by maybe speaking something? The formulation usually is kind of arrived at after at least about 4 to 6 sessions, and there is a lot of information that goes into it. So, for every kind of statement that is there, there would be kind of some clinical information that is available. So, if you want to clarify certain things, so Shubham and Anup, you had put up your videos and then you have closed them. I think you should get back to it. Therapy is usually learned in groups. So unless you are, yeah. So thank you, Anup. बाकी लोग भी आप लोग अपने वीडियोस ऑन कर लो, मतलब उन्हीं अक्षय सजल ऐश्वर्या, राइट. सो अनूप, आप कुछ बोलना चाहोगे? मतलब जब तक आप लोग सब लोग एक एक लाइन नहीं बोलोगे आगे नहीं जाएंगे.
Or if somebody wants me to read through again, walk you through any part of the formulation, you can let me know. I can take you through that. If you guys did not understand any part of the formulation.
ओके, आई थिंक ठीक है. हर्षिता, कंटिन्यू मे बी.
Yeah, at the end.
Yeah.
Okay, so When it comes to responses in therapeutic situation, so in treatment, Mr. SRK, that is my client, at first was quite ingratiating, holding this good son position, condemning himself for his past and present failures, expressing that he may not meet the therapist expectations, which actually was seen in other interpersonal relationships also. So after few intensive sessions, when therapy sessions were spaced out, which discomforted him, subconscious aggressive impulses cropped up in the form of self-mutilating behaviors.
Okay.
When the yeah,
Rishita, I think we'll go a little slower from here. Like when you say that uh, he wants to hold the good son position, condemning himself. So does he abase himself? Is he trying to be just a good son, or does he show himself as a person who is actually not good enough? Is it more a good son position or an imperfect son position?
hmm. So
The
So it's kind of, yeah. So if I try to explain in terms of object relations, the psychic conflicts which is running through him, so he actually, with respect to father, he tried to be more submissive. He's tried to be more, apologizing for all his failures. So trying to be more inadequate, that is actually good son position. Holding that inadequacy itself is kind of a good son position for him. So
then when
he
you
also tried with the therapist. He tried to say, he tried to be more, ingratiating. He tried to be more appeasing to me, telling that he may not meet the expectation, exposing his inadequacies. Uh, that itself is an obedient son. And no, the definition of obedient son, which he has carried throughout his life.
Yeah. So he's trying to be obedient, but he is consistently self-abasing. He
Yeah,
consistently kind
punitive.
of
Yeah.
shows himself to be a person who's inadequate in most ways. After that, you have talked about that the therapy sessions were spaced out. So
Yes,
why
sir.
were they spaced out?
So initially, when he was admitted, he was in an inpatient setup. So, and actually, I was a treating JR, junior resident at that point of time, and I was the one who did the case summary, and then I switched over to be a therapist. I took it as a therapy case. So initially, the sessions were bit intensive because it was an inpatient setup. Then, as it became outpatient, then the therapy sessions were more spaced out.
And
So,
when they
but
were spaced out, how frequent
as
were they?
in, so when I was an inpatient setup, it was like weekly, twice or thrice session. But when it became an outpatient, it was weekly once.
And does it recollect anything in his life, that spacing out of sessions?
Mm, Not exactly, if I remember, but it was showing up. I mean, he was not telling anything, he was not recollecting anything with respect to his objects, that his mother, relationship with his mother, father, or the perpetrator. But there was definitely this affective symptoms were used to worsen whenever there was spacing out.
Yeah. Like his mother left him after 1 year. The person that we are calling the perpetrator, even though that relationship was 13 to 16 kind of, and I don't know whether he sees her as a perpetrator or not, but he was definitely uh, disturbed when she left rather than being disturbed when she was there. So in his
Yes.
mind, I think there is ambivalence around that relationship. So whenever people leave him or distance from him, he has some issues there. Okay, let's continue.
So, So when it was spaced out, which discomforted him, subconscious aggressive impulses cropped up in the forms of self-mutilating behaviors. When the
So do you want to
therapist,
interpret this that whenever people kind of distance themselves, he harms himself?
you're asking me something, sir?
Yeah. So how would you interpret this? In
It is in terms of object relations.
Yeah. So you have put it in uh, technical terms. In simpler words, how will you explain this?
So
So
it was.
instead of
Uh,
being a presenter, I'm not shifting you to being a teacher because
uh,
people are not asking you questions directly. So I'm asking the question that people probably would ask. So you have to
uh,
kind of try to explain. So you now
uh,
are a teacher in that sense.
So in his case, whenever there was spacing out happening, so he used to bring up the self-harm behavior, the self-harm ideas, telling that he had this collection of glass pieces, that he had this repetitive thoughts that he wanted to harm himself. So when the sessions were intensive, I was not getting such self harm ideas that frequently in the sessions. But when it was becoming spaced, that's when this self harm ideations became more frequent. Um,
Here, what seems to be happening is that when spacing out occurs, he seems to blame himself that I am somehow responsible for the spacing. I did
Spacing out.
something wrong. That's why people are. So that's why you have what is mentioned here that subconscious aggressive impulses. So the aggressive
Yes.
impulses are because I am bad. That's why this is happening. So I have to kind of hurt myself.
Yeah,
Yeah.
and spacing out is an act of rejection for him. So this perception that somebody is rejecting him brought out this more the aggressive impulses, telling that I am inadequate. I am the one who's not who caused this distance, and he brings this aggression is directed towards the self.
Right.
So when therapists reciprocated with anxiety, because I remember I was a first year JR when I was doing this therapies, I was taking this therapy session. So I was training. So I had certain amount of anxiety, which
So
was a
suppose we say that that is a rationalization.
yes.
So can you
So
reflect whether it could be something else?
yeah, it was kind of counter transference that I experienced whenever he brought up this self harm behavior.
Would it
Uh,
be something other than being a first aid? Well, you have said that it's countertransference, but it's not just a realistic thing that you were not trained enough at that point.
yeah,
So could
yeah.
there be
So
something
if I
else?
have to reflect that way, so I can reflect in the way that he bringing this self harm behavior put me into that state to give him more attention, to give him to interact with him more and give the more sessions, so that kind of maybe his behavior to improve the proximity between himself and the good object.
Yeah. So look, this is something that we often see that when you meet borderlines and they start self-harming and they're trying to regulate a distance, they're trying to pull you in a relationship. You're trying to maintain a certain distance, they're trying to pull you in. And that leads to anxiety. So the fact that you're the look, this is not something that only a first year GR feels. This is something that all therapists feel at all times, that when borderlines try to pull you in, they're trying to merge the boundaries and there is discomfort around that merger. So almost everyone feels anxious in these situations. Yeah.
And and there was actually he actually went into a depressed state, and there was second admission. So I had to temporarily cessate the therapy because of the second admission, because the patient had to be posted to ECT, and the other biological treatment was ongoing, intensive biological treatment. So there was temporary cessation of the therapy. So, and the patient introjected perfectionism and fear of loss of this desired object, and he further got depressed and climbed on to become the further depressed. So, after
So
this,
from an analytic perspective, the patient worsened, and the therapy team kind of looked into magical solutions. ECT the next जरूरत लग रही है. मतलब, instead of managing it psychodynamically. मतलब, I'm not saying that this is a wrong decision. I'm just saying that we shifted from dynamics to something which is different for the time being. In a way, we are trying to recalibrate the distances. Yeah, let's continue. Yeah.
Actually, I had
so yeah, yes, sir. There,
was the distress more during the abuse from the perpetrator, or when the perpetrator actually left?
it was when he left, when the perpetrator left, that's when the distress was more, and it ended in self harm. It's the self, that's the point of initiation of self harm.
So how do we actually conceptualize this aspect?
So the
So
perpetrator is an older lady.
Yes.
And he is in a relationship with her. We don't know the nature of the relationship exactly,
yes.
whether it is how sexual the relationship was. But there is something which is at least quasi-sexual there. And it's not necessary that he sees that as entirely abusive. There may be a
Mm,
certain degree of
yeah.
consensuality there, except that by legal terms, it is non-consensual, that he's too young. So there is
Mm,
non-consensuality also. He's just 13 years when the relationship kind of starts becoming sexual. So there are incestuous element in it, but there is also a certain degree of desire. Probably, I'm not certain about it, but there's a possibility that since he shows discomfort at her leaving, it means that there was a certain degree of desire into the relationship also.
so there was emotional attachment to the perpetrator, because initially she was caring, the he actually looking forward to meet her every day. And later when he said, as per the patient, when he said it became sexual and she imposed on him, that's when he started getting distressed. But as sir mentioned, how far it is non-consensual, we don't know, because now at that point of interview he said that the sexual relationship was non-consensual. But we really can't interpret at that point of time. So but her abrupt the withdrawal, disconnection, made him get into the self-harm behavior because of heightened distress.
Which is quite understandable considering the kind of incestuous nature of a relationship. Even though she's not a family member, but there is that
Yeah.
older, younger person, so a mother, son kind of a sexual relationship. So even if there is the positive desire, there's also a guilt associated, and particularly when the relationships are ambivalent, when they get broken, often people feel that I am bad. The other person is withdrawing rather than I am withdrawing. The other person is withdrawing. So it suggests that the other person is rejecting me, and rejecting me after abusing me. So it's a kind of a double rejection in that sense. Harshita, don't take my statements to be fully accurate because I don't know the person directly. So if you feel that I'm not accurate in places, please feel free to kind of clarify those things.
Sure, sir. So, after this, I had to, after the second admission, and there was a cessation of the therapy session, and the patient became more depressed, and there were ECT the biological treatment happened by the treating team. Later on, I continued for few sessions, and I had
We'll
to
just
hand over.
we'll just ECT को dynamically कैसे देखा जाता है? Anyone
Mm,
has kind of read it anywhere? Harshita, you would like to
is
take
it
it?
like? Hmm. Is it like okay? So ECT, is it like
You are right.
I'm just trying to the make interpretations here, sir. I have not read anywhere, but is it like a punishment, or is it like a magical treatment, getting not able to address, not able to process, but somehow just like this dissociation of self harm, getting into the trying to
Yeah. The
get into immature defenses like dissociation, not able
like
to address his emotions.
ड्रीम्स में जैसे कुछ स्टॉक इंटरप्रिटेशंस होते हैं, they are not always the right interpretation for individual cases, but the stock way of looking at ECT is that it's magic on the part of therapy, that the therapist believes in magic, and the patient sees it as a punishment. And when
Hmm.
they are properly punished, their the guilt is assuaged to a large degree. So they feel that I have done something wrong, I have been punished adequately, now I can move on. Look,
Hmm.
look, this is a very kind of a stock interpretation, so you don't have to apply it to every case. This is just one way of looking at this.
So, after second admission, after the biological treatment, I had taken few sessions with him, and later I had to hand over the case to another therapist. Um, so, because of my academic commitments, so again, he that was felt as a rejection. I did not have the direct contact with the patient, but I did follow up with the therapist and the treating team, but there was a dropout from the therapy, and also he did come for follow-ups with the treating team for a few more months. However, he dropped out from the therapy, and I had to do a teleconsultation for him after a year or what he reported is that he had better functionality and decreased suicidality. And also, he started reporting that he started expressing anger towards parents transiently when there was minor disputes at home, which may explain kind of possible catharsis and a symptom improvement. While during the sessions itself, he was able to recognize that he lacked assertiveness. He was able to recognize that he lacked ability to stand for his opinion, and and counter argue when things are not right. So maybe that's one of there might be inside development during the journey of the therapy sessions, and this might have started manifesting outside the therapy environment in the real life, is what I interpret. But unfortunately, I lost this patient's follow up later on.
Right. So, are there more slides?
Yes, sir. This there are two couple of other slides. So, if I have to make implications of the case for the client, it is like allowing for the development of a relationship with a good object, that is therapist, by therapeutic alliance, which allowed him a safe space to express this childhood trauma. Then anticipating that the raised inclined sense of self-esteem will be associated with denigration of therapist and him clamping down to become temporarily depressed. There was partial reduction in symptoms after dropping out with therapy, with the ability to express anger and assert for his needs, which was reported in teleconsultations. Though the patient was aware of his deficits and roots of it was uncovered, but patient remained unaware about the cause of this change. So, for the therapist, understanding more about transference, countertransference, and their role in therapy, as well as dealing with resistance and various ways it can be worked through. Learning to maintain the delicate balance of confronting or challenging the patient's immature defenses while also attempting to preserve the strength of therapist patient alliance, and learning how to empathize and not identify with patient, that is how to make the patient felt understood without losing objectivity or becoming over involved with the patient. So that is it.
Okay.
These were the implication I could make.
Right. So, questions, comments from participants. I will request everyone to put their videos on at least now.
Sir, I had a question.
Yeah.
When therapy was restarted after the patient had self-harm attempts, once you recognized that it was secondary to the abrupt stoppage of therapy, so how did you deal with that?
So I first thing is that I try to ask him like what how is he feeling? How did he feel with the spacing out of therapy sessions and cessation of therapy session? How did it make him feel? So he tried to again obtain himself into the good son position, telling that he felt that because of his uh, the not working through well in the therapy session, because the alliance was not good with the therapist, that's where this spacing happened. He did not work well as a patient. He did not meet the therapist expectation as for the improvement, and he his self-harm behavior and his depressive decreased functionality uh, made the therapist disappointed the therapist. So all this self-punitive behavior, self-punitive thoughts came through in the session. So I try to make this reflections in the other interpersonal relationships also, with this mother, maybe with his father. The that, or it can be with the any relationship which he felt close at that point of time. So he came up with this feelings that any rejections he's unable to handle in the healthy way. That was his reflections. So I think these are the insights that developed within him. And I also asked him, so if he was announced of spacing of therapy sessions, why didn't he oppose, or why didn't he bring up that he's not comfortable with spacing out? Because he has this pattern of always being an obedient client, and getting himself into that meek and submissive position, agreeing with things. So again, he brought up telling that he also sees that his behavior, there's such patterns in his other interpersonal relationship as well, that he can't speak against people's opinion, because he fear losing them. So I could bring about the insights when within him that what he's lacking in the exercise of pleasing other people.
Okay, thank you.
Any other questions? Okay. I think Varun, I'll try to put the whiteboard here. Let's see whether it comes.
So if I am allowed to ask question,
I think I'll get back to you. Just stop sharing the slides
yeah,
for a moment. I'll just make something on the whiteboard and then we'll get back to the discussion.
sure. So I have stopped sharing.
Yeah, the whiteboard must be
Yes.
available. Okay. So one of the theorists in psychoanalysis is named Fairbairn, and Fairbairn is a kind of he's taken tiny and thought further. So he's in the same school. He's an object relations person. So what he says is that uh, initially, when children are born, they have a central ego and they have a good object. So a good mother, a good. So and this object is not a person. The object is the totality of all the object relation that the person sees. So if there is a good mother and a bad father, the object will have inside the psyche, it will be a combination of the mother and the father rather than separate. And each person is not a separate entity. Is the
Mm.
overall whether the objects are good or not kind of a thing. But as people grow, usually there will be frustrations, and after the frustrations come, there will be aspects of the object which are good, which is called an exciting object. So when you, it's something like that when the uh, let's say with a dog, when the owner comes back, the dog is all excited, jumping up and down to meet the dog. So that is the exciting object, and that is the libidinal ego, the ego which is attached. So libidinal is not sexual in that sense, but libidinal is something which is attached. And there is similarly the other side of the object is a rejecting object. So the object which either doesn't pay attention, is neglecting or abusive, angry, that kind of thing. And the the ego which protests against it, the protesting ego, is called the anti-libidinal ego. So the anti-libidinal ego usually is angry. It may do passive aggressive things like self-cutting or abusing. It's basically trying to blame the object that you are not doing good to me. So the point that I'm trying to put across here is that when we talk about objects in the psyche, they are caused by what the people outside are doing, but inside the psyche, the objects are kind of composites. They are not individualized in that sense. So that's just a point that I wanted to make. And also, when we talk about, so this is inside the mind, usually it's not good objects and bad objects kind of a thing, in the sense that some people are not good and some people are not bad. It's more that there are good aspects of the object on the whole and bad aspects of the object on the whole. So this is something like the actually the good object is this one, the ideal object, which is doing the right kind of stuff. The exciting object can be like the lady who he had a sexual relationship with. So she was an exciting object. So exciting object doesn't need to be a good object. Exciting object can have goodness also, but it's essentially something which attracts. So there is an attractive object, there is the balanced object, and there is a rejecting object. So the point again that I wanted to emphasize is that objects inside the mind are not people. They are a composite of people. Okay, we'll get back to the case proper. Yeah. The chat, there is something. Okay. So Harshita, you wanted to ask something?
Yes. So, sir, in the conference where I presented this in WADP, so we had discussions, and you also brought up some of the theoretical concepts, as in if the personality disorder wise. The Kernberg's, Otto Kernberg's, how is this, if in with respect to this case, where does it fit in the personality classification is the question you had asked. I did go back and went through the Kernberg's theory of personality, of normal personality and abnormal personality, and how has he classified this of neurotic personality organization, and high, middle, and lower bipolar disorders. So,
High, middle, and lower borderline.
sorry, I'm so sorry. It's a slip. So, borderline personality disorder. Sir, if we take this Kernberg's theory, personality organization, um, so if a person with middle or lower borderlines come for the therapy session, it is almost like a psychotic spectrum.
When Kernberg talks about psychotic spectrum, he doesn't mean psychosis in the schizophrenia form. Psychotic spectrum generally would mean that a person will have paranoid defenses. A person may have
Mm,
quasi-psychotic breakdowns. So it is not always that the person will be schizophrenia. It's not
okay.
process thing. It's more that they function close to psychosis.
Differences that they use. So, if we have to progress in the therapy, um, if the are we bringing this client from the low or middle borderline to a neurotic spectrum and becoming a normal personality?
Yeah, normal people are neurotic spectrum. So we are trying to kind of take them up from the
Lower,
suppose a
middle,
person is quasi-psychotic, then you are trying to get them to middle level, maybe to upper level of borderline. So often, however, the problem is that people who are very immature, they will not engage in psychotherapy, and so it's
mm,
more difficult to work with them.
yeah,
People and the parameters of therapy for people who are kind of middle borderline or higher borderline is different from what you will do for neurotic spectrum people. So in a very kind of a broad manner, if you're dealing with borderlines, object relations methods may be the object relation theorists say that you will have to apply object relations to borderlines, because the problem with them is of a two-person psychology. Like
yeah,
they haven't even
splitting.
dealt with the child and the mother relationship well.
Mm,
While to be neurotic, you have to come to a three-person psychology, which is father, mother, and child. So the object relations people say that to deal with borderlines, you have to use object relations, and when they come more organized, then you can start using the more classical ego psychology kind of
okay.
methods. The ego psychologist would argue that it's not a fixed thing. The different schools will follow different logics, but in general, it's believed that borderlines do better with object relations, and the more mature people will do the uh, even object relation theorists start applying the ego psychological principle once the person is on the neurotic spectrum.
Neurotic spectrum. Okay.
So in him, the borderline elements are that he has difficulty with boundaries. So whenever people are drawing apart, he starts feeling that there is a certain degree of abandonment. He tends to worsen following that. He has a lot of self-harm efforts. He does self-harm things. He deteriorates functionally in a significant manner when relationships are unstable. So,
Yeah.
So there are many things which will kind of suggest that he is at a borderline level of functioning, and borderline level of functioning is not equal to borderline personality disorder. So in borderline organizations, schizoids, antisocials, narcissists, borderlines, hysteroids of the histrionic kind, all of them are considered to be paranoids. All of them are considered to be borderline at
Borderline.
different levels
Okay.
of function.
Yeah. Understand.
Okay, so more questions?
And very interestingly, I read that DSM-5, the newer personality classification, has adopted Kernberg's level classification of the personality pathology.
Yeah, the alternate model and the ICD-11 also, when they talk about personality disorder, they're talking about disorders of personality functioning. And that concept is similar to Kernberg. It draws quite a lot from Kernberg's principles, but they have termed it in ways which are more theoretically neutral. So, suppose it should be possible to use the ICD and DSM-5 alternate model along with
Right.
schema therapy or mentalizing therapies. So different kinds. So anything which kind of talks about personality functioning on a whole rather than seeing personalities as different from each other.
Right, right, sir.
So it will fit with all those models. But it draws very heavily from Kernberg's model.
Yes, that's why the newer classification doesn't categorize them into schizoid or borderline or paranoid.
Yeah. Yeah. So Varun, how long is this session? Is it for 1 hour or is it 1.5 hours? If it's 1.5 hours, then we'll go back into certain things. If it's 1 hour, then I think we are beyond.
So it is for an hour, but we can definitely stretch and it's a great learning experience as always. Wow.
So anyone else wants to kind of raise questions, issues? One thing we have to understand that this is the year, uh, first year kids therapy, and in that sense, it's there is a lot of material which has been conceptualized in dynamic terms. The main thing that I kind of expect in therapy supervision is that you learn how to see clinical phenomena and start labeling them in dynamic terms. In the sense कि अगर case में आप देख रहे हो and you can say that okay, this particular phenomenon is obsession, this phenomenon is delusion. That's what is important from half of psychiatry is being able to do that kind of labeling. So in a similar way, from a psychodynamic perspective, you can see something and you say that this is uh, there is a denial here or there is a uh, uh, let's say projective identification there, there is projection there. So those are the things that you have to pick up from clinical materials. So you see a description, you say okay, this is this. So uh, the main idea of supervision is to get to do that kind of brass tacks things, a small thing that you see a description and you try to give it a label, and that as soon as you label you start understanding. So if some of you want to ask Harshita about how she came to certain labels, it may be a useful exercise. Okay, so will Kumud, do you have any questions, suggestions, comments?
Also, I can forward my psychotherapy formulation summary to all, not the presentation, the formulation that I submitted for the institute to the students. If they are interested, they can go through that, and that can help them in guiding for their therapy sessions.
Sir, I would like to ask like how you label something as an object, like how do we define as an object? Like the in this case, the patient has attached himself to a car that his mother has brought him. Like, how do we like? Is there any criteria or something?
There is no criteria. The object, as Sir said, it's not an object mother. It is the patient's own the view about mother as a good part of the mother, as a good object. So usually when the identity is consolidated, if somebody in a normal personality, if the identity is consolidated, they can see both good part in a person and a bad part in a person, and they see that a person has both good part and bad part, and they are able to integrate it. But in cases of splitting, they're not able to integrate it. They see that mother who is caring, loving as a good object, and the mother who is unavailable, and who is abandoning the child is a bad object. So object is the client's perception about the mother.
It's the internal representation of the mother. The perception, in the sense, it's not a conscious perception, it's an unconscious perception. So as she mentioned, that if they are able to integrate, they see that all objects will have good and bad qualities. But if they're not, if they're still split, they see that objects are either good or they are bad. They're either love rejecting or they are exciting. So that is, and the toy cars are called transitional objects. So transitional objects are things which are close to the original object, the important original object, which the person gets attached to. And since they're able to play with that, like for example with a toy car, if he's able to play with it, he is attached to the toy car, it tells him that my mother is somewhere near, emotionally near. So it helps him to manage the distance between the mother and himself. So there's a person by the initials SR, which is very similar to the initials of the patient, SRK, and also to the great Khan. So would you like to say something? So did the patient identify with SRK?
No. Sir, actually, he is from Andhra Pradesh, and his family name is also associated. So I have taken the initial of the family name as well as his name. So it is a 3-part in his name.
So that's split object.
It's very distant from SRK.
Okay. So SR, do you want to say something? Okay, Sajil?
Yes, sir.
You want to reject us completely?
Using psychodynamic terms in session, if people can't ask the question, so that they become familiar with the terms.
Okay, so Nitisha?
No, sir, no questions.
Okay, it's very unusual.
Just joined a bit late, sir.
Yeah. Nitisha usually has questions. Okay, so Rajiv Savan.
Sir, I had joined just now in the end of the session. We had another session. Nitisa was also there. So I'm very sorry, I've joined late.
Right. Okay. Rajshekar Reddy.
Sorry, sir. I also joined right now. So
Okay.
I should not have said that.
No issue. Dr. Prasad? Right. So, is there anyone
And
else?
just make a final request, sir. And I do know that the trainees, they have a tough time in understanding the terms. And I do know that in my PG days, we used to read Oxford textbook of psychiatry. Actually, it did talk about the dynamic concepts to a certain extent. To be honest, it was understandable also. If, sir, the trainees are to sort of start a reading, what would be, sir, your advice, and so that they can also be, I mean, conversant and they can actually start labeling, like you're saying, actually. My understanding is that these discussions otherwise also do not happen in the work. So a lot
See,
of
there
it is
is,
self-driven, maybe a bit.
yeah. Uh, the first book that I would suggest is Hall and Lindsay, Theories of Personality. It's a book which is followed by all IAS trainees who do psychology. So that talks about Freudian psychology and other kind of psychology. So at least the chapter on Freud is a very useful thing to begin with. The second book which will be very useful is Anna Freud's defense mechanisms. So Anna Freud is the first one who gave defense mechanism in a systematic manner. So if you do that, it will be useful. Uh, mm, Other than Wahlberg, obviously, is a very good book to learn psychotherapy from. Wahlberg, actually, the nice thing about Wahlberg is that it gives a lot of clinical material and derives terms from there. It tells you how to go about doing it. So even though it looks like a big book, actually it reads fast. So the if I have to talk of very basic books, I would talk about Theories of Personality, Wahlberg, and Anna Freud's Defense Mechanism. Other than that, if you Kernberg writes in a way which is accessible. Kernberg has chapters in CTP, some of those are the middle volumes. So the reading original chapter of Kernberg from CTP, probably about 5, 6 or so, that would be pretty useful for understanding the object relations part of it.
Mm.
But in reality, you learn psychotherapy more by talking on cases. Reading books sometimes gives, reading books is good because it gives you an overall kind of a picture. But that transition from clinical to practical, that is only obtained through, with something like reading fish versus doing actual cases and coming to apply various concepts on real cases. So reading fish, you can finish in about, maybe if you read it steadily, you could finish it in 3 days. But learning psychopathology takes at least 6 months to be somewhat conversant with it. It takes about 6 months. So that is the kind of. एक पेरी क्रिस्टोफर पेरी का वर्क
1987
होता
article.
था. नहीं, not the article. There used to be kind of a booklet in which he has talked about defense mechanism, how to rate defense mechanisms. So if you can get hold of it from somewhere, usme he's talked. He gives the name of a defense mechanism. He says how it can be rated at different levels, and he gives clinical examples of how to go about doing the rating. So that is a very good way of learning how to kind of label defense mechanisms. उसका नाम कुछ, पेरी का डिफेंस मैकेनिज्म रेटिंग स्केल टाइप का कुछ है वो, जो इट्स सो ईच डिफेंस मैकेनिज्म इज डिस्क्राइब्ड इन वन पेज, एंड देयर आर probably about 40-50 pages of that. So it's like a workbook. It's very useful to pick things.
Thank you.
Otherwise, I will think of other reading material. मतलब ये मेरा top of the head से मैं ये बोल रहा हूँ, but there would be other things which may be good to start. Single book if you have to read, मतलब एक chapter खाली पढ़ना है, then theories of personality का Freud will be that chapter. And the next I would talk about, if you can get Perry's, it's better, but otherwise Freud, Anna Freud's defense mechanism is a good book to read. It's a small book. It's a 90-page kind of a thing. So it's easy to access. Freud's own lectures are very nice. मतलब सबसे accessible way में, if you want to read psychodynamics in absolutely accessible way, that is Freud. Because he is written for lay people. Like when he started writing, there were no psychodynamics people, so he's written everything for lay people, and they're very easy to follow. एक किताब पढ़ना है तो Interpretation of Dreams was the most fun of all his books.
So for me, while I was preparing this formulation, the articles which helped me was Perry's 1987 article and the Summers article. The Summers is the recent one. These two articles will help in good psychodynamic formulations.
I would stick with Perry's article more than Summers, because Perry actually describes how to do it. Summer is adding more things to it.
Updating the Perry's.
So Perry का original में फायदा ये है कि वो कैसे करना है exactly, he tells how to do it. And since it's simpler, there are fewer things to capture. For learners, it's better to go by Perry's. For more advanced people who have to present, then Summers becomes, because it gives you additional things that you can add. Yeah, Perry, I think, is a very good suggestion. Okay, so I think we'll close here, and if Harshita, you have a kind of a last minute summarizing statement, that would be useful.
So what I would, for the students, what I would tell is that, the good way of learning psychodynamic is to take, first of all, psychodynamic cases and start applying psychodynamic principles in the therapy sessions, because as per my knowledge, not many people follow psychodynamic schools of therapy in their practice. They mostly, it is now the third wave therapies have come, mostly they apply that or CBT. It is all but there are many cases. It's not that one school of therapy is right and the other school of therapy is wrong, but learning psychodynamics, it is initially difficult, but it is really enriching as you go through the journey.
Sure. What I know is that most psychiatrists actually apply dynamic schools of psychotherapy, because most of the time you're doing supportive psychotherapy. So you're using concepts like catharsis, ventilation, those kind of things. So most of the people actually apply dynamic, but they do it in a supportive mode. Many of you understand defense mechanisms, and you are applying it to your patients without realizing it. You often know that the person is in denial or the person is rationalizing and so on. So actually for psychiatrists, psychodynamics is more accessible because it's been a kind of a natural part of our training for a long time. All older psychiatrists were all dynamically oriented. So, and since most of your teachers were dynamically oriented, they were not dynamically trained, but they were oriented. So they have passed on those kind of things with generations. The other kind of model which we use without really realizing it much is client-centered kind of psychotherapy. So supportive and client-centered are the standard methods of doing. Standard means the easiest methods of doing therapy. All other methods have to be learned. So if you want to do more interpretive psychodynamics, you have to learn that. If you want to do CBT, DBT, or even the third wave, acceptance and commitment therapy, all of them have to be learned more specifically. But if you don't learn things specifically, you will either be doing something close to supportive or client-centered therapy. So knowing dynamic therapy is good from that perspective, that on a day-to-day basis, you apply dynamics to your patient's interactions anyway. The other things have to be done in a more formal manner. So you need to have at least 30-minute sessions for CBT, while dynamics you're doing any which way. As soon as you're interacting, you are doing a bit of dynamics. Okay, so I'll now hand it over to Varun for his concluding comments.
Thank you, sir. We are hoping that we have a renewed wave of interest in dynamic therapies. And I'm hoping that we continue the case presentations, though we're still working on the format. I hope that we sort of have a uniform format. I did speak with Harshita, but she did not, it was just not possible to put in the session notes. But sir, we'll try again in the next presentation to have the session notes, and we'll see as to if we can have the formulation in much more easier and simpler terms and make it more accessible to the trainees, if I can put it that way. And uh, we hope to continue this. That's all I can say. So thank you, sir. Thank you once again. Thank you everyone that you've joined in. Thank you, Harshita, for presenting your case and giving us an accessible presentation. So thank you so much. Thank you once.
One other article which is very good is the Glenn Gabbard article that I think they had circulated. So that could be a model of how cases could be presented, particularly if people want to present formulations. Right? It doesn't cover the entire case, but it covers formulation very well, how to use clinical material to formulate. So maybe you can circulate that to people.
Yeah, we'll do that.
Perry and Gabbard's articles.
Sure. I don't have the Perry answer. I'll search it and I'll circulate that.
Okay.
I'll send it to you, sir. I have it.
Oh, great. Thank you. Thank you, sir. Thank you, everyone.
Thank you.
Bye.
Thank you all.
Good night.